changes. Okay. Well, thank you, Mr. Chairman. So, this is my conflict of interest. The classification of LUTs, it doesn't differ a lot between men and women, actually. So we have always storage problems or storage symptoms, voiding symptoms, and post-nutrition symptoms, just to put in mind when we are treating or dealing with overactive bladder. So the ICS definition of overactive bladder is urgency, frequency, and nocturia, with or without urgency, incontinence, in the absence of a local disease or pathology in the bladder. If you look at the International Consultation of Incontinence algorithm and recommendation, they look first at the initial management that is done by non-professionals. And if you look here, they started with the presumed diagnosis, because it is not the full diagnosis. And at that time, they can go on with a differentiation between the symptoms, but not in a very accurate way. And for that, they are only entitled to do lifestyle interventions, pelvic floor muscle training, bladder retraining, or maximum give antimuscarinics for the treatment. If this fails, and most of the time it does, so you have to go to other things, which is external electrical stimulation or vaginal devices. And if not, then you need to go to the specialized management by urogynecologists, urologists, or even gynecologists. So this can be done only by specialized doctors. For the specialized workup of these patients, you need to do some clinical assessment that will include urodynamics. So urodynamics will be here important for the full diagnosis, not the presumed diagnosis. And then you will be able to entirely diagnose and categorize the symptoms into intrusive overactivity incontinence or overactive bladder incontinence. So if you go and give the initial therapy and the antimuscarinics or whatever drug therapy, then you will have only left to go with botulinum toxin and immunomodulation before going to surgery. And this is the message behind this, that you need to go through the guidelines as of the International Consultation of Incontinence, or the European one, and to know that spectrum of treatment for non-joint bladder dysfunction is to start from the less invasive to the more invasive. So you start with the lifestyle advice and behavioral approaches through the assisted emptying, and then the intermittent cassation, for example, or go to pharmacotherapy, mainly antimuscarinics or beta agonists, and then you go to either Botox or neuromodulation, which one is the first. This is what we are going to discuss, and at the end, the surgery, augmentation or diversion. So this is the spectrum, and this is how you need to think, start in the treatment of overactive bladder, to start with the less invasive to the most invasive. This is the Cochrane review about the electric stimulation in over 63 trials, and it proved to have low quality of evidence because it is really not working very well. And these are the pharmacologic agents, mainly are antimuscarinics with the beta-3 adrenergic agonist here. All the antimuscarinics have level A evidence, 1, and recommendation A. So they all work. The difference is which one is more effective, which one has more side effects, which one you can escalate with the dose when it fails. So this is the only, but all of them will work initially. This again, Cochrane review showing the trials for anticholinergic versus non-drug therapies, and you can see that anticholinergic were compared with bladder training alone, and it is definitely more, there is more symptomatic improvement with it. Comparing anticholinergics versus other drug therapies, only few or small-scale randomized trials were found. Many drugs are no longer used. Clinical examples, the flavoxate. There is inadequate evidence to assess whether or not available alternative drugs are better or worse than anticholinergics. And comparing anticholinergics versus anticholinergics, there is no compelling evidence for differential efficacy across medications. Standard release better than immediate release in terms of side effects. So, for example, sulfenafcine is better than tolterodine immediate release, while physiotolidine is better than tolterodine extended release. So patients with more severe symptoms, on average, will experience greater symptom reduction with the treatment. And comparing again the Botox with the placebo, the Botox showed to be significantly better than placebo in relieving the symptoms. And comparing the Botox, for example, with sulfenacin, the efficacy of onabotulinum toxin A and sulfenacin was significantly higher than that of placebo. However, onabotulinum toxin A showed significantly greater decreases in urinary incontinence than sulfenacin, with a third of patients achieving 100% incontinence reduction. So there is no unexpected safety signals observed. And comparing the Botox versus mirabegron, the study indicates that onabotulinum toxin A may be superior to mirabegron in improving symptoms of urinary incontinence, urgency, and urinary frequency in patients with idiopathic overactive bladder. Botulinum toxin exerts its activity by prohibiting the release of neurotransmitters from autonomic and somatic nerve endings, and it doesn't cause neuronal death, and the effect is temporary as toxin is inactivated and degrades with time. So you need to tell the patient that she or he will need to re-inject after 6 to 9 months. It is administered via intra-detrusor injection under local, regional, or general anesthesia using a rigid or flexible cystoscope, while no protocol regarding the location and number of injection is universally accepted. So you can inject 20 or 30 and you can make the geographical distribution yourself. This is the injection of botulinum toxin. You can inject it intra-detrusor or even in the ridges or of the detrusor muscles appearing under the mucosa, or even sometimes we put it submucosally, and it both works very well. This is a video, but I have no tools here to run, so this just shows how to insert the needle and how to inject. You don't need to go very deep, otherwise the needle will transfix the bladder wall. So sometimes there are needles with side holes, so it gives the toxin into side without transfixion of the wall. The FDA approved the indication of 100 units of botulinum toxin A diluted in 10 ml preservative-free saline, or 200 units, and you can dilute it in 20 or 30 according to how many injections are you going to do, because each injection will take 1 ml. Your assistant will inject it for you while you are looking inside. So the injections to the trigone have traditionally been spared out of concern for producing zygomatic reflux, which is not true in all the studies. And several studies have shown trigonal injection to be safe and effective without evidence of reflux. If we look at the sacral neuromodulation, the objective is to rebalance the micturition with electric stimulation of the sacral nerve roots, mainly S3, on patients with chronic micturition troubles. It raises the inhibitor mechanism of the micturition reflex, and with the electric stimulation, the exact mechanism is poorly understood up till now, and it needs expertise in every phase. So, comparing the sacral neuromodulation with anticholinergics, the study demonstrates superior objective and subjective success of sacral neuromodulation compared to the standard medical therapy. Sacral neuromodulation is shown to be a safe and effective treatment for overactive bladder patients with mild to moderate symptoms. So there was a comparison between sacral neuromodulation and Botox injection, because they are the second line of treatment after the failure or in response to medical therapy. So we have the Rosetta design study with women with urgency urinary incontinence refractory to medical therapy. We will have at least 6 incontinence episodes per 3 days, and they compared the InterStim versus Botox 200 units. The rate of clinical response you find at a reduction of at least 50% in urgency urinary incontinence episodes on the 3-day bladder diary was similar in the injection and the neuromodulation groups. And this was measured at 1 month in the injection group and during the test phase in the neuromodulation. In the intention to treat analysis at 6 months, the change in the mean number of daily incontinence episodes from baseline was greater in the injection group than in the neuromodulation group. So more patients in the injection group with Botox, than in the neuromodulation group achieved complete symptom resolution at 6 months and a reduction of at least 70% in the episodes per day. So it was 46% versus 26% for neuromodulation. These graphs show again the change in the mean episodes of the urinary incontinence episodes and the frequency episodes. So it's again in favor of the injection with Botox or monobotulinum toxin A. So the overactive bladder symptom bother score measured by the International Concentration Incontinence Overactive Bladder short form were significantly better in both groups after treatment. But the change from baseline was greater in the injection group than the neuromodulation group. So all these results showed that the Botox injection was in favor than the neuromodulation, and in the treatment satisfaction was better in the injection group than in the neuromodulation group, as was endorsed and assessed by the overactive bladder satisfaction of treatment questionnaire. At 6 months, the rate of urinary tract infection was higher in the injection group. So there is something here that we have to look at, that these patients of the Botox had urinary tract infection more than the others, and in the injection group, intermittent catheterization was required by 8% of patients at 1 month, 4% at 3 months, and 2% at 6 months. So we have two problems here, the urinary tract infection and the need for intermittent catheterization, while in the neuromodulation group, 3% of the patients required surgical revision or even removal. So both have good responders for the treatment. There is a greater reduction in the symptoms for the Botox group, with complete resolution of 20% versus 4% for the neuromodulation, and 70% reduction of the episodes in 46% of the Botox group versus 26% of the neuromodulation group. But they have more urinary tract infection and intermittent catheterization need, while the InterStim group has 3% revision. So both treatments have high response rate, high cure rate for the 200 units of botulinum toxin versus the neuromodulation, and this is again is the side effects. The question is 100 units that is approved by the FDA is enough for the non-neurogenic overactive bladder? Would the same results come in men like women? And for the long-term follow-up in terms of cost effectiveness, which one would be easier for the patients? So both are third-line therapies for overactive bladder, and to be used after therapies such as behavior modification, pelvic floor exercise, and medication are not effective. There's really been no clear-cut guidance on whether you should do one or the other, and whether to use the 200 units or 100 units, because sometimes 100 units are not effective in these patients. If you look at this graph also, it will show that many of the treatments, whether antimuscarinics or mirabegron or PTNs or second neuromodulation or Botox or placebo, they are all there in the graph and all scattered there, with placebo being scattered everywhere, but they all have a role and all are working. So it depends on the baseline symptomatology and the magnitude of the placebo effect. How to choose? You have to go to the guidelines and to read it carefully, and it's according to your experience. Do you know how to inject Botox? Do you know how to do neuromodulations or not, for example? And what is your expertise with the drug therapy and with your clinical practice and setting, and of course the patient preference. It's important to deal with your patient and see what kind of treatment can go for. So there are predictive factors, the doctor preference is important, and the patient information, and of course the reimbursement and the cost benefit. So this all guides us in our decision which is the best line of treatment we need to go through. So I want to thank you for your listening and attention. Thank you very much.